Hello and welcome. Today, we're diving into what is, without a doubt, one of the most important roles we can play as pharmacists, helping manage a patient's symptoms in their final days. This is all about practical, compassionate care when it matters the most. Let's get right into it.
So, picture this. The phone rings. You pick it up, and on the other end is a caregiver. You can hear the stress in their voice. They're telling you their loved one is agitated, struggling to breathe, just really uncomfortable. And they're looking to you, right then and there. What do? This isn't just a hypothetical. It's a reality we face, and our expertise is absolutely critical in that moment.
And that phone call isn't an outlier. The data shows us exactly what we're up against. The top 3 symptoms in the last 48 hours are noisy breathing, secretions, at 56%. That's more than half of patients. Right behind that is pain at 51%, and then restlessness or agitation at 42%. These are the big 3 we really need to be ready for.
So, here's our game plan. First, we'll talk about the clinical context and how our goals have to shift. Then, we'll cover the big changes in prescribing. After that, we'll get into the nitty-gritty of managing pain, dyspnea, delirium, and secretions. And we'll wrap up with what is maybe the most important part, your role in counseling and monitoring.
Okay, first things first. We have to start with the most fundamental concept. Because in these last days of life, our entire way of thinking about therapy, it has to change. The goals are just different now.
And here it is. This is our new North Star. The goal shifts from trying to cure to providing comfort. Full stop. We are there to limit suffering. Our absolute priority is to help the patient enjoy whatever time they have left. And that means we have to actively avoid things that might just drag out the dying process.
Right. So this huge shift in our goals, it directly impacts what we do with medications. We're basically playing by a new set of rules now, where simplicity and comfort are everything.
And these are the 3 big rules. Number 1, we get really aggressive with deprescribing. The statins, the blood pressure meds, anything that isn't giving comfort right now, it's got to go. Number 2, swallowing gets harder, so we need to switch our essential comfort meds over to subcutaneous or IV routes. And number 3, this one's key. We use anticipatory prescribing. That means having medications for pain or nausea or agitation right there at the bedside before the crisis actually happens.
All right, let's get into the specifics of managing symptoms. And we have to start with the 2 heavy hitters, pain and dyspnea, or that feeling of breathlessness. This is where your opioid toolkit becomes absolutely indispensable.
But hold on. Before we even reach for a medication, we need to remember that this is a team effort between non-drug and drug approaches. Simple things can be incredibly powerful. For breathlessness, just repositioning the patient, or having a small fan blow some cool air on their face, or providing calm reassurance. These can make a huge difference, and these are fantastic counseling points you can give to a caregiver.
Now, for the pharmacologic side, the evidence is really strong for using opioids to manage that feeling of breathlessness. If someone's in acute distress, 5 to 10 milligrams of subcutaneous morphine can bring relief really fast. For just keeping things under control, the standard is regular dosing every 4 hours, with as-needed doses available every hour for any breakthrough symptoms. And notice what's not on the list: nebulized opioids. The evidence just isn't there, so we stick to the systemic routes. Now, when you're setting up that as-needed or PRN breakthrough dose, there's one number I want you to remember: 10%. The gold standard is to calculate that dose as 10% of the patient's total scheduled opioid dose over 24 hours. That gives you a safe, effective dose to have ready to go.
And of course, we have to track how often those PRN doses are being used because that's our best guide for titrating the regular dose. This formula here shows you exactly how to do it. To get the new scheduled every 4-hour dose, you just add up all the opioids the patient got in the last 24 hours. That's both the scheduled doses and all the breakthrough ones. And then you just divide that total by 6. Simple.
Okay, let's talk side effects, because managing these is a huge part of your counseling role. The key here is to know the difference between the temporary stuff and the stuff that sticks around. You can reassure caregivers that, nausea and drowsiness are super common at first, but the body builds a tolerance in a couple of days. Constipation, on the other hand, that never goes away. It is absolutely mandatory that you start a regular laxative regimen from day 1. That's such a critical teaching point.
And this right here. This might be the single most important thing you can say to a family. They are often terrified that giving morphine is the same thing as causing death. You need to be able to look them in the eye and say with confidence that the evidence shows when we dose opioids correctly to control a symptom like pain or breathlessness, they do not hasten death.
Okay, Let's switch gears and tackle our next set of common symptoms. We're going to focus now on how to manage terminal delirium and those respiratory secretions.
When it comes to delirium or agitation, haloperidol is still a workhorse. But, agents like olanzapine are fantastic alternatives, especially because they have a lower risk of those extrapyramidal side effects. But the most important thing on this slide is what to avoid. Unless there's a specific reason, like alcohol withdrawal, you want to stay away from benzodiazepines like lorazepam. They can actually make the delirium worse.
All right, let's talk about respiratory secretions, sometimes called the death rattle. The first and honestly most important thing you can do here is educate. You have to explain to the caregivers that even though that sound is really upsetting to hear, the patient is usually completely unaware of it and isn't suffering. Just reframing it for them is a huge act of compassion.
Now, when we do need a medication to help dry up those secretions, we're usually reaching for an anticholinergic. And the choice between the two main ones really comes down to one key side effect. Scopolamine works great, but it crosses the blood-brain barrier, so it's pretty sedating. If adding more sedation is something you want to avoid, then glycopyrrolate is the better choice because it doesn't have those same effects on the central nervous system.
Okay, let's bring all this clinical knowledge home and focus on how you actually translate it into clear, effective communication. This is where you go from being a dispenser of medications to a true counselor.
Think of this slide as your cheat sheet for those critical conversations with caregivers. You need to reassure them about the temporary opioid side effects. You've got to stress why that bowel routine is non-negotiable. You have to reframe noisy breathing as a sign of deep rest, not suffering. And you have to repeat that vital message. Comfort care with opioids is not euthanasia.
And please, don't forget your active role in stopping things. Providing comfort isn't just about what you start, it's also about what you stop. You should be advocating to discontinue burdensome things like routine vital signs, blood work, and almost all of those chronic disease meds that just don't serve the goal of comfort anymore.
If you only take one single thing away from our chat today, let it be this guiding principle right here. Every single decision you make, every recommendation, every phone call, it should all pass through one simple filter. Does this choice provide comfort? So I'll just leave you with this final thought. At the end of the day, your goal isn't just to manage the symptoms yourself. It's to transfer your knowledge and your confidence to the caregiver who's right there at the bedside. So the real question becomes, how can you use everything you know to empower them, to give them the tools and the peace of mind they need to provide comfort with confidence in those final precious hours?